behavioral health. And you have with you tonight Dr. Aurora and Rob Jones.
Yes, sir.
Please identify yourself as you speak.
All right. I'll start. I'm Anna White. I'm an attorney. I do a variety of healthcare services. I'm ranging from autism and representing patients and their families as we try and make sure they have proper access through behavioral health in the substance abuse treatment area. I'm a frequent foe of the cabinet, so I always appreciate when they're here to watch us. Doctor, identify.
Yes, my name is Dr. Praveen Arla. I'm a primary care physician practicing in Bullitt County.
And I'm Rob Jones. I'm the Executive Director of Community Action Kentucky, the poverty fighting network of 23 community action agencies around the state of Kentucky.
And every time we hear the cabinet say how many more people in the state are covered by insurance, we automatically should turn around to Rob and his agencies and say thank you for running most of the Connect program and for doing the interface between the local communities and the registrations. These guys do fantastic work. Telehealth is something that I hadn't really considered until my clients started coming to me and saying other states are using telehealth to cut healthcare costs and, to use the cabinet's impetus, increase access and increase flexibility. We're also used now to using our smartphones and our computers and our tablets. We're all connected all the time, and we don't realize what a valuable medical tool that can be. There's relatively cheap and easily available HIPAA-compliant software. You can conduct medical discussions and examinations and counseling that is scrambled from outside people directly to patients, even via phones and very easily via personal computers. We're seeing a lot of more progressive states realizing that we need to access this technology to help medicine. In Kentucky, we do have a telehealth law, but it's limited to a very few registered locations, and they're primarily big hospitals, not your rural hospitals, and CMHCs, community mental health centers. There are dozens and dozens or hundreds of providers across the state who could be using this technology to reach patients. And just as importantly, community action could be leveraging their pass-through state and federal dollars and reaching hundreds more people in their very rural, low-income communities if they could do this via screen rather than having to drive to every community to offer the services. We need to look at, particularly with substance abuse in Kentucky, finally, thank you all, we have a piece that requires counseling. You don't just give somebody medication and hope that they take it and hope that they don't sell it on the street and hope that they get better. We require pill counts. We require patient check-ins. We want that doctor or that provider to see that patient, see how many pills are left, see that you're looking sober, see that you're having a job. We like that face-to-face, but that is not very cost-effective. The same with counseling. We want people to go to counseling, but often these are addicts. They don't have jobs, they don't have a babysitter, they don't have gas for the car. How are we going to access counseling for those people in a very cheap and very easy way? And the answer is telehealth. A lot of the large substance abuse providers in the state are going under the radar and doing this. If they have a counseling center in one city, they're saying, really, it's not telehealth, even though our clinic, where the patients are looking at the counseling screen, is 100 miles away. And the cabinet's sort of tacitly approving this. That's not a very safe system, and it's also not an easy way for providers to get paid. No health insurer is going to cover you if you're not qualified to provide the telehealth. So we need to all start talking about this as a community and figure out what we can do to expand that so that providers across the state and patients across the state can more easily access this incredibly valuable service. We want patients to do the peer counseling every day. We want the counselor to see them, and we want them to have more access. And my big concern, being old and not used to internet security, probably 5 years ago when a lot of these regs were enacted, we didn't even all use our credit cards online. There are still people I know who are afraid to shop online or buy things online, but it's safe. And with patient contracts and with the software we have today, we can do this in a very safe way. The patients can consent, there are written forms. It's exactly like a face-to-face encounter. You can't touch the patient, but you can provide many of the other services to many more people for much less money. And I will turn it over to the experts because I'm just the lawyer. So go ahead, Rob.
Well, I'm just a lawyer as well, but I'll do my best as an expert also. Community Action Agencies Kentucky, the goal is to pull people out of poverty by providing a bundle of services that are needed. Usually it's not one service or another, but a group of services that are needed to help a person return to self-sufficiency. Historically, we've done social programs, we've done aid programs, but consistently what we found, especially through the administration of the Connect program over the last 2 years, has been that one important piece is quite often either access to health care that is not available either because of geography or economic problems, as well as access to counseling and continued intensive services that may not be possible in a rural area. We have the infrastructure to provide the counseling services or work with other providers to ensure that there is access for the low-income community in the rural areas of the state and many of the poorer areas of the state where these practical limitations have prevented access before. It's good for us because we can then bundle those into the other social services we provide as a part of our goal to get the people out of poverty and get these benefits to the people who need them and quite often just simply can't avail themselves of them. That's all I'm really here to say. The doctor is the expert, but I wanted to let you all know the importance of what I think telehealth can provide to the poorer rural areas of our state, even the poorer metropolitan areas of our state, frankly, and that we stand ready with the infrastructure to assist.
So once again, I'm Dr. Praveen Arla. I'm a primary care physician, born and raised in Kentucky. I'm currently practicing internal medicine and pediatrics in Bullitt County. I'm also the medical director of the health department in Bullitt County for the last 4 years, and I also hold a master's degree in public health. I've been the chief medical officer for a company named Imperium Health Management, which is also owned by Almost Family. Imperium basically organizes groups of physicians into accountable care organizations that were mentioned earlier today as well. It helps them deliver cost-effective, coordinated care to the elderly here in Kentucky. So my goal today is basically to highlight the ability of technologies and to improve patient outcomes in their home and significantly reduce state expenditures. My practice, we have a significant population in both Medicare and Medicaid as well. So I do want to thank you for the hard work enacting presumptive eligibility, and also Secretary Haynes and her staff on working on the bill and the work on the certificate of need, because it's all very important. But I want to get back to what I'm passionate about, and that's taking care of my patients and the elderly population here in Kentucky as well. I mean, implementing technology, telemedicine, telemonitoring can be scary because of the unknowns, but a lot of those unknowns have actually already passed. If you've noticed, telemonitoring has repeatedly proven to be critical in the health management of elderly living in rural areas with diabetes. Several states have actually have already put this in place, including Mississippi as well. It's been deployed in Indiana also. Basically, it involves using easy-to-use interactive technology for patients in their home. Skilled nurses work with patients and technology to detect worsening conditions. The goal is trying to avoid hospital admissions. In my own practice right now, I have my own chronic care management program. And, once a month, the issue is that when a physician and the patient leaves my four walls, the patient's pretty much lost until they come back to the next visit, whether that's a month or 3 months, or if they have an exacerbation. So I put in place simply to put in a center where I have my nurses call them, trying to figure out what's going on with the symptoms in term, right? With telemedicine, could you imagine the value add with telemonitoring? Basic vital signs can be life-saving. There are several physicians on this committee as well that know this. When we're looking at rise in blood pressure, spikes in weight, blood sugar rises, desaturations and oxygenation as well. I mean, very simple examples would be congestive heart failure, watching a patient's weight, whether it's increasing or not, if they need to do medical changes, especially with COPD as well, watching oxygen saturations. Remember, Kentucky is among the very worst in the nation in prevalence in these chronic diseases and is 50th in the nation in related preventable hospitalizations. I plan to live my remaining days here in Kentucky, and I hope I don't fall victim to these statistics. Like I said, it's extremely important to get this in the power that it actually improves to the primary care physician. I've been working on this for quite a bit now. I'm very excited to work with you on developing legislation and bringing benefit to Kentucky seniors and family caregivers. I'm open to any questions at all.
Any questions? Senator Carroll.
Thank you, Mr. Chairman. Talk a little bit about the billing aspect of these services and how that